Hey, good evening, ladies and gentlemen. How are we doing this evening? There we go. That's much better feedback than we tend to get in the classroom. So I like that. Fantastic. Well, first and foremost, welcome to the beautiful SMU campus, and in particular to the SMU Cox School of Business. My name is Todd Milborn. I am the new dean here, or relatively new. I think I get to say that for about 3 more months. The dean and Tollison chair in business leadership here at SMU Cox. I am delighted to be here to welcome you for this evening's event, Collective Impact, the intersection of health, business, and innovation. We are incredibly pleased to partner with Parkland Health on this event, showcasing the importance of the convergence of health, business, and innovation. The Cox School is proud to serve as a convener to host this collaboration among leaders across the corporate and nonprofit sectors to advance health equity in Dallas County. Parkland has been a strategic partner with SMU Cox since the inception of our healthcare initiative in 2022. The Healthcare Initiative is a multidisciplinary program designed to shape the future of healthcare in North Texas by combining academic research, industry collaboration, and executive education. The goal is to bridge the gap between clinical training and business leadership by helping healthcare professionals develop essential soft skills, strategic insights, and expertise in the areas that are all very top of mind, like artificial intelligence, operations management, pardon me, and data analytics. Vishal Ahuja, SMU Cox Associate Professor of Information Technology and Operations Management, otherwise known as part of our ITOM department. Vishal is also an adjunct faculty member at UT Southwestern Medical Center, and he is a key player, in fact, my lead person in helping to lead this initiative on behalf of Cox School and all of our partners here. Vishal was slated to serve as a panelist this evening. Unfortunately, Vishal had a family emergency that made it impossible to join us tonight. So I'd ask you, excuse me, please keep him and his family in your thoughts and prayers, if you would. He sends his regrets. He and I have been in email communication. His flight finally got overseas as he returned home to India, or to see his family in India. But he is confident you're going to find the discussion tonight enlightening. To that end, our panelists and group that are here tonight, Dr. Fred Cerise and Dr. Michael Horn, have served as featured speakers at all three of our healthcare conferences. And we also welcome Melissa Thompson from the McKesson Foundation. You're going to meet all three, and I'm sure you'll hear a little bit more on their bio during the panel discussion that will kick off here in just a moment. I'd like to also mention that both Dr. Cerise and Dr. Horn have sent Parkland leaders to our AI for Healthcare Leaders Executive Education program in the past. We are very much, this is a little bit, we're going to really cajole you here, very much looking forward to hosting them in our fourth cohort of the program that kicks off here in 2 months. The Cox School AI for Healthcare Leaders Executive Education program is going to take place across 2 days, Tuesday and Wednesday, April 21st and 22nd. If you'd like more information, there should be a slide above. Do I have to advance it? Slide, oh, there we go. This is it. A slide above with the additional information about that, as well as other exec ed programs that are coming up this spring. I'm also incredibly delighted, and it speaks to the fact that healthcare and the business thereof is one of the fastest growing industries, not just in Dallas, but all of North Texas. We have a new student club here at SMU Cox, the SMU Cox Healthcare Business Club. In the audience this evening, I looked around to make sure that we've got a couple of students here. In the audience this evening, we've got some of the students who are members of the Healthcare Business Club. Would those students in the audience just give a little wave? Make sure, there we go. We got a couple there. We got a couple in the back. Students always go in the back. Make sure you network. This is the next gen of top leaders in the industry. It's great to have you here. The formation of the Cox School's new Healthcare Business Club is an example of the growing student interest in pursuing careers in the business of healthcare. Having this event in particular right here, right on our campus, is a great opportunity for them, but clearly for all of us. So I want to thank you, our students that are here, all of you that are in the audience for attending this evening. I know you're going to really enjoy it, and I'm looking forward to it myself. With that, My work here is done. Let's get to people that know something about healthcare rather than just their script. So to kick off the panel discussion, I'd like to invite to the podium Dr. Michael Horn, President and CEO of Parkland Health Foundation. Please join me in welcoming.
Awesome. There we go. Thank you so much. All right. Good evening, everyone. Awesome. Let's try it again. Good evening, everyone. Wonderful. In my former life, I taught 24 kindergarten students. And so you can only imagine how we would start our day with joy and zest. And by the afternoon, I was tired like everyone else. And so here we are. Thank you, Todd and SMU, the SMU Cox School of Business, for just your awesome hospitality this evening. We are thankful at Parkland for our partnership with you and the support that you all have provided us over the years. But it's only befitting, I think, that we gather tonight at SMU in light of the positive news that has recently been generated. I'm sure many of you have read in the paper, and I was certainly thrilled to learn of the recent $50 million gift and contribution to launch the Boulevard Society. And so it's clear to me that SMU continues to borrow from that 1996 classic, Jerry Maguire, right? Show me the money. They tend to do it. And so glad, as the fundraiser in me is in this space, glad to be amongst such an august group. Tonight, we are excited to share some exclusive insights from Dallas County's Community Health Needs Assessment and discover how collaborative leadership is advancing health equity. For those of you who don't know, the 2025 Community Health Needs Assessment, also referred to as the CHNA, was jointly conducted by Parkland Health and Dallas County Health and Human Services to identify the most pressing health challenges facing Dallas County residents. As required by federal law, this assessment and its findings are produced every 3 years, combining quantitative health data with extensive community input to guide public health planning, healthcare delivery, and community investment. Now, while we won't be covering the entire report tonight, you will find a QR code in your program that will take you to the digital CHNA report. And I would encourage you certainly to peruse and read it at your leisure. It is phenomenal bedtime reading. I've done it over the years, and I would encourage you to do so yourself. But tonight, throughout our conversation, we're going to highlight several key findings from the report, and we certainly invite you to continue to explore it more depth. Now, quick housekeeping item before we begin. Later in the program, you're going to see a QR code on the screen where you can submit questions for our panelists, and we're going to do our best to get as many questions as possible following the panel discussion. And so, now that we have set the stage and prepared the table, it is my honor to introduce this evening's panel. And you will find their full bios for our panelists in your program. And so please join me in welcoming to the stage Dr. Fred Cerise of Parkland Health and Melissa Thompson, McKesson Foundation. All right, let's settle in and get comfortable here. And so to kick us off, Dr. Cerise, I'm going to start with you. At a high level, I would love if you could really describe what are some of the most important insights from the Parkland's 2025 Community Health Needs Assessment, and if you could highlight, what is most surprising to you when you think about this report relative to past reports?
So I'll just start by saying I'm a little bit intimidated because I've read the CH. It's still a work in progress. It's becoming finalized. But the person who's done all of that work, Teresita Oaks, is right here. Raise your hand, Teresita.
Yes.
She has led this effort for the past several years, and so knows it inside and out. So you're going to have to keep me honest, all right? So I'll give you a few of my kind of initial takeaways on some of the insight. First off, not surprising. Chronic disease, cardiovascular disease, cancer, continue to be the leading challenges that we're dealing with, not unlike a lot of places. And so those conditions are still sort of top of the list of things that we've got to be paying attention to and impacting. And a number of those things are impactable, right? The things that lead to cardiovascular disease like diabetes and hypertension, absolutely. treatable, identifiable, treatable. We don't do a great job of that as as a society, but the opportunity is absolutely there. Cancer, a lot of cancers are preventable. We tend to do a pretty good job when people come into our systems to identify and treat. But a big part of the work that we're going to have to continue to do is how do you get out into the community and identify stuff early on rather than waiting for it to come to you. So chronic disease continues to be a significant issue. Disparities comes out once again. You see areas where that's actually getting a little bit better, and some of the areas where we've targeted efforts over the years, where you're seeing some narrowing of those disparities and some improvement, diabetes and some zip codes where we focused efforts, or we're seeing some success there. But it continues to be, whether it's chronic disease, cancers, we continue to see disparities, particularly among blacks and others, in terms of higher prevalence and worse outcomes. Geographically, apart from race, but just looking at geography, many of you, if you've read the CHNA in prior years, you'll know that there's a wide difference in life expectancy among zip codes that are just a few miles apart in Dallas. So if you're in 75205 compared to 75215, there's over a 15-year difference in life expectancy based on just that bit of geographical difference. If you think about that, if you are a black male in 75215, your average life expectancy is about 63 years old. So you've worked your life, paid into things like Social Security, Medicare, and you'll never take advantage of that. And so those disparities still exist. And that map that the CHNA outlines essentially becomes our guide to where you need to go and focus your services. So those are a few things. Behavioral health continues to be an issue, and it's growing. You're starting to see more people identify as having behavioral health challenges. Significant increase, over 60% of the zip codes. We've seen significant increases in people who are self-reporting. They've had bad mental health days in the past, over half of the days in the past month. And so behavioral health continues to be a big issue as well. And then finally, from the qualitative portion of this, because Teledesitas' team will do a lot of focus groups and surveys, and when you're looking at that information, it's not surprising that people are saying we need better access and better affordability to healthcare. I'll tell you, this used to be a problem of low-income people, and it was sort of concentrated in that demographic. But this is becoming a problem that is, that spans demographic groups now. Access and affordability. Some of the insights on that, maybe we'll talk a little bit more about that, but people want, they need a primary care doctor. They need something that's not 6 months from now. They need something that's available at a time when they can get to the doctor. They want to be able to get everything done at the same time. We see this show up by people coming and waiting in the ER for a long time because they want a one-stop shop. They don't want to have to go 3, 4, 5 times to get their stuff done. So those kind of insights came through loud and clear.
Yeah, that's really helpful. And I think for many of us, just this idea of access to high quality and compassionate healthcare where we live, work, and play continues to resound, right? And really stick out for how we think about kind of changing or reimagining the healthcare service delivery model. And so look forward to picking up on some of those themes as we continue our conversation. Melissa, the McKesson Foundation continues to make significant investments in improving healthcare access and innovation, especially through philanthropic partnerships, such as the partnership that you've had with Parkland, for which we are grateful for. How does community level data that we're talking about, and Dr. Cerise kind of kicked us off in our conversation with, such as the CHNA, really inform the work of McKesson Foundation as you think about where to place your investments across the community?
It helps us an awful lot. So we're really fortunate that the McKesson Corporation funds the foundation. So with that gift, we also have the responsibility to make sure that we're making smart investments and how we choose to support organizations and programs across the region. And in particular, knowing that there are so many great organizations doing such important work, sometimes you got this wealth of opportunity and this much money, so a lot of the data that's in your report helps us prioritize those options. And so we know that with the evidence-based data that's in the report, we have reliable information, not just my gut or the influence of a really talented development person or a physician, but helping us understand from a objective, data-driven perspective, what are the gaps to care, looking at the disparities in outcomes, and then where are those locations where there are the biggest gaps and the best opportunity for us to make a difference. And I think the data from Dallas County shows us things that maybe national or state level just doesn't get to. And so there are instances where we might have similar programs, but in different neighborhoods, because we know from the data, from the anecdotal quotes, I love the quotes that were in the preliminary report from the patients, that being near that care could be the difference between them getting it and not, right? You can't spend an hour on the bus each way. You might not have a reliable car. So good example, Bonton Farms and Jubilee Park.
Yes.
We support wellness centers at both of those locations because we know that people in those communities go to them and they appreciate that they can walk there. So seeing how people access care, what might be the barriers that prevent them from adhering to their treatment once they start, and then navigating all the intricacies of a healthcare system, that information is found in your report, and we're able to draw on that when we're assessing the scores of applications that we get every year in just Dallas alone to help us understand where are we going to be able to make the greatest impact and provide the best support for patients as they are looking for health education, screening, treatment, aftercare, all of that.
Love it. Thank you for sharing that, Melissa. I mean, this idea of agency and how data can certainly increase agency across the board is really important, and really appreciate you lifting up some examples. I mean, Jubilee, where we have clinical presence, continues to be a model for how we can really consolidate comprehensive services and provide that continuum of care. So thank you for sharing that. Dr. Sweets, I'm going to go back to you. You talked a little bit at the beginning of your comments about chronic diseases as something that continues to be prevalent across Dallas County. And so we'd love if you can really kind of mention how the CHNA is really speaking to how the burden of chronic disease is actually evolving, right, over time. Who's most affected? What are you seeing across Dallas County in terms of just the prevalence of chronic disease?
Yeah, well, as I mentioned at the outset, unfortunately, we're not seeing those numbers go down. I mean, we see similar impact of cardiovascular disease, the things that lead to that, primarily things like high blood pressure and diabetes, continue to be areas that we know we have to focus on. The thing about those chronic conditions, I mean, we could talk a little bit more about some others, like cancer is another leading cause of death, and there's many opportunities to intervene there as well. And so as we look at this, we're looking naturally for how can we impact this, not only at Parkland when people come in and show up, but how do we intervene at a population level? At UT Southwestern, I had a guy named Tom Frieden, who was he was a director of the CDC, among other positions that he held, and they had him doing their grand rounds for the School of Public Health a few months ago. And he wrote a book, and it was heavily focused on hypertension and the opportunities and the missed opportunities there. And if you look at that, it's almost half of adults have blood pressures over 130 over 80. Only about 60% of people know that they've got high blood pressure. And then when you look at who's effectively managed, it drops down to like a quarter of the population that is effectively managed. And so there's a huge opportunity if we were able to organize better and do a better job of intervening. And so I bring him up because the things that he'll talk about why we don't do a better job of this in U.S. healthcare. And he focuses on things like, well, the payment system doesn't incentivize it. You know, we pay episodically for care. You go to the doctor gets paid for that visit, end of story. And what you really need are teams that are doing this. You need multi-specialty teams. You need pharmacists in there, care coordinators, nurses, all working together to do this. And you know, I see a few Parkland people here, and you'll recognize this from, we had our leadership forum a few weeks ago, and I mentioned we have got to get more aggressive with this because all of the things that Frieden identifies as barriers, we don't have. You know, we as a public health system, heavily funded by flexible public money, we can invest that way because all of our interventions are not based on an office encounter. And we do have those programs, but hopefully, I don't want to, but hopefully we can get a chance to talk a little bit more about some of the stuff, how we're using IT and those team-based models of care to get to some of those chronic conditions at a level where we can make more of a community impact as opposed to kind of the individual impacts.
Well, let's dip our toe in the water if we could, and that is let's talk about diabetes, which you mentioned, right? So when you think about what has been kind of offered, right, whether it's the book that you were referencing or other interventions, what are some of the things that you're seeing, right, in terms of what we could be doing to more dramatically, right, address the prevalence of diabetes across Dallas County?
Yeah. So, at the base level, there are a lot of interventions you can do that are non-medical, but they're really hard, I mean, when you tell people exercise, lose weight, eat right, those are easy to say, hard to do. When you look at the community health needs assessment and you look at some of the areas where you've got the higher prevalence and it's tougher to manage, it's the same areas where they say, well, I don't have transportation, we don't have food, we don't have grocery stores that have healthy foods in our neighborhoods. And so, you can say those things, but okay, you got to do. We have to do more than that. So, we have a food as medicine program now that you guys have invested in, and so Dr. Jacqueline Albin leads that program for us and looks at among people with diabetes that have food insecurity, how can we develop meal plans that speak to what are the needs there to effectively treat their diabetes. So food is one thing. If people could get on a healthy diet and consistently, you could get off of medications for the people with type 2 diabetes. And so it's a tough thing to actually do though. So, but that's one example. There's a lot of drugs now. There are many, many more options than when I was treating people that are available to you. And so we're looking at our programs. How can we make these programs available to people with diabetes? They laughed at me at our team a few weeks ago when I said, we've got all these, we can cure diabetes. We've got to do a better job. And they said, cure diabetes. But if you think about it, if you're doing continuous glucose monitoring and you're on the right drugs, you can really manage this disease and avoid all of those bad things that come with diabetes. And so, investing in things like how do you identify the people who are poorly controlled and focus your efforts? Because we can't, medicine there's so much need. We've moved beyond sort of the guidelines where I used to practice of everybody gets this, and everybody that has diabetes gets these things. We have to get much more granular and personal now. And so we can look at our records and see, okay, who is poorly controlled and not taking their medicines, for instance. We know we're writing the prescriptions, but we have fill data. And so are they actually getting it filled? That's a roadmap to somebody to say, okay, we know it's treatable. We're prescribing medicines. Why aren't you taking it? Is it you don't believe it works? You're afraid of it? You can't get it? What's the barrier there so that you can then go and treat that? And so now we have an entire digital health team that does this type of work, and it scans the record to see who's poorly controlled, how do you do targeted outreach for those individuals and get them better controlled. And then as they can work with those people, get them under control, then hand them back to their primary care provider to maintain the care, so they're not seeing them forever.
Yeah, yeah. It's interesting. Todd, you mentioned there are students in the audience, and what an amazing opportunity to really apply the logic of solving a business problem, right, to healthcare, right? Are there ways that we can disrupt the traditional system, as you mentioned, Dr. Cerise, to transform the ways that patients are receiving much more personalized care for things that we can control? And so I think that the solution is out there. There are many solutions, and exciting to see how that can play out in places like Parkland and other partners. Melissa, I'd love to turn from diabetes to cancer. And so certainly cancer continues, as we talked about a little bit earlier, to place a heavy burden on Dallas County. When we look again at the CHNA, even with the advances in screenings and treatment, I think between 2021 and 2024, it's an interesting stat, Parkland saw a 19% increase in patients with cancer-related conditions. And so we've talked a little bit, and you've done a good job of really talking broadly about the work that McKesson Foundation is doing and the support that you're providing. We'd love to drill down. How is the foundation really focusing its support and initiatives around cancer care? And where do you see nonprofit partners across Dallas taking more unconventional approaches, as we talked a little bit about, to addressing some of these gaps?
We look at cancer care from the very beginning with awareness, helping people understand what are your cancer risks, what might you be able to do to lower the risk, understanding when they should start being screened and the cadence for screening. It's not necessarily one time. And then treatment. And then how do you support patients while they're going through treatment?
Yes.
And so everything from that first appointment to treatment, huge barriers, transportation. And so we support partners that provide either door-to-door transportation for a patient, money to help them cover it. We also have partners who provide funds for people who might need help making the rent or their mortgage or their car payment, because when you get a cancer diagnosis, that can upend your entire financial infrastructure, right? And so whether you are an hourly worker and missing a couple of shifts because you are on treatment and not working, or you are having lots of out-of-pocket expenses, or some people have to travel a great distance to go get their treatment. There is a huge financial burden. So we have partners who help with that. And then making sure that you are looking at your nutrition when you are undergoing treatment is also important. And so we have partners that provide medically tailored meals. And one in particular is right in Fort Worth. It's called Cuisine for Healing. And it's all organic food, starting with all the ingredients, but also the seasonings. Everything is organic. They have choices for people, so it's not, this is what you get on Tuesdays, and it's delivered to them, and it's free for people who are eligible financially. And then there are also many patients who can't afford it and they choose to pay for it because it's one less thing for them to worry about, or they might be too weak to go to the grocery store and do their own shopping. And that Cuisine for Healing is right in the medical district of Fort Worth. So they tell sad stories, but important stories about a patient getting a diagnosis, the healthcare navigator telling them about Cuisine for Healing, and before they go home, they go to Cuisine for Healing and sign up for meals. So all of these different things, when you think about the social determinants of health and all the things that affect your health, they also affect your ability to withstand and adhere to treatment, which is so important. And sometimes when you hear the reasons for why somebody stops, whether it's, I need to be at work, I couldn't afford it, I didn't have anybody to watch my kids, all of those things just make you so sad when you realize it's a short-term problem, but it's creating a long-term problem. So partners are doing really innovative things to provide resources in real time exactly where they need it. So that's, again, why we do some of these pockets. But then there are also two organizations I want to mention that are national that do fantastic work. One of them is called Immerman Angels. So cancer diagnosis takes a toll on you emotionally and mentally. Immerman Angels is a great organization. They do peer mentoring, and it's for the patients, for survivors, and for caregivers. I mean, I was recently a caregiver for someone, and it takes a toll, and they do such a marvelous job of reaching out and identifying people who've been through a similar journey, having these one-on-one conversations with them, and finding those little truths about themselves, so that when somebody needs a mentor and they talk about what it is they're looking for. So an example that I remember the director told me, a woman was in her early 30s, had young children, and was a marathon runner. And she's like, I'm gonna have to give up my running to do this. I'm like, no, you're not. We know somebody. And they connected her with somebody who, in her 30s, young kids, how do you talk to your kids about this? And then how do you continue to run if that's what really brings you joy? And so it's so successful. They've made tens of thousands of mentor-mentee relationships. Some of the mentees, after they finish treatment, actually become mentors. And it's just the psychological lift of somebody who has been where you are. And I really appreciate, right now they're doing this big effort to reach out into more rural communities, because they want to find those people who've been through it and can help somebody who's now there. And then another cool organization is called Triage Cancer. It's founded by 2 attorneys who knew that going through cancer treatment can be miserable. On top of the physical stuff, there's how am I going to manage my job? What are my rights? And so they help with financial and legal navigation. So helping you understand, how do you maximize your health insurance if you have it? How do you make sure that you are using all of the benefits available to you? And it's training for a patient or caregiver who calls, and they also train healthcare navigators in doctors' offices and hospital systems, so that they can be a good resource for people who are just trying to figure out, how do I pay for all this? How do I manage all these different places I have to go and all these new people in my life?
Yeah, as I'm listening, I'm just thinking about and you mentioned this, Dr. Cerise, the complexity of just healthcare, and the fact that there are so many components that we need to attend to. But if we center the patient and really think about more holistically, what are all of the factors that go into someone's health journey, right? And then design programs and interventions in that manner, there's a great likelihood that we can lead to success and really disrupt some of the kind of legacy outcomes that we've seen, and certainly that we continue in some ways to read about in the CHNA. And so I think lifting up those examples of innovation and disruption that may seem unconventional, right, but eventually become the norm,
Exactly.
right, is really important. Thank you for sharing those and really highlighting the power of philanthropy to really be the bridge builder, right, and barrier buster. And so that's really interesting. Thank you.
It's commentary on our health system. Unfortunately, though, like the stories you talk about, people with cancer, it's a leading cause of bankruptcy for people.
Yeah.
The number of people with cancer that end up bankrupt because they happen to get cancer is astounding, and it really speaks to the need, like the work that you guys do to help with that. Medical debt in general is a huge and growing problem, particularly in Dallas and Fort Worth, and areas where you've got high uninsured rates. But cancer particularly is such a challenge. And so, on top of having to deal with that, then it's piling on that you've got all these financial problems on top of that. So thanks for the work that you guys do.
Yeah, that's it.
We're pleased to support the partners who are doing the work. And when you hear this individual stories of people who forego treatment because they say they can't afford it, or they don't want any more debt, or they finish their treatment, a year later they're wondering, oh gosh, has it come back? And there are people who will say, I don't want to know because I can't take on any more debt to
Right.
manage it. And it's heartbreaking.
Those are real stories.
Yeah. And so these organizations that are doing this, it all came out of necessity, and they are delivering real measurable results to see the outcomes for people who are able to stay in their home, or have less emotional trauma going through it, or just feeling better supported through it.
Well, I want to stay in this theme of support, and again, being very targeted and intentional in the ways in which certainly your leadership, the McKesson Foundation, continues to show up in our community. The McKesson Foundation, in that vein, supports several pharmacy school programs, and so we'd love to talk about kind of the work that you're doing to expand access, right, to pharmacies and pharmacists. What are the ways in which that work is really showing up, particularly in under-championed communities?
Well, and in lots of communities, the pharmacist is kind of their first or easiest access to care, and particularly in rural areas and some urban areas. I mean, we support a program at the University of Illinois Chicago, and they have a rural program and an urban program.
Wow.
Entirely different, but to help those students understand how to serve the patients in those respective communities. And so we have about a dozen pharmacy school partners, and fundamentally, all of them are looking to increase the number of underrepresented in medicine students who will go there, and then train them so that they can operate at the top of their license, meaning whatever, this it varies by state what a pharmacist can do, but whatever you are able to do with your pharmacist license beyond the counter, we want to help you learn how to do that. So for instance, University of New Mexico, they have, I think if I remember the numbers correctly, it's 33 counties and 30 of them are medically underserved. And so every pharmacy school student has to do a rural rotation for graduation. Well, we're funding a second rural rotation for them because they knew and have evidence, documentation, that when the students go to these medically underserved areas and they see the impact they can make on the patient care and the improvement of patient health, they're more likely to go live and work there once they graduate and have their license. And so we want to give them extra time in that community. And it's a win-win because the patients are getting care and assistance they might not otherwise. And then the student is likely to go back there.
Right.
And so we have another one, University of North Carolina. They reach out to all the HBCUs in the area to help them see that this is an income, a job that offers a livable wage and an opportunity to do something that you can see the impact of every day. And they offer them a student program or a summer program, so they can come in and they can work with pharmacists and the students and see what do those interactions look like. What does it mean when you go out in a mobile unit and you're giving vaccinations, or you're helping people with manage their blood pressure, or you're doing the medication therapy management, and somebody comes with a bag full of medicine, and you're like, no, you shouldn't be taking all this anymore, and helping them understand what should you be taking, when, what with food, and what do you need to talk to your doctor about and maybe not take anymore. But all of those experiences help them see that there's so much more than, here's your prescription, do you have any questions? It's really great for them to be involved in the community and offering them that one-on-one connection point. And sometimes it's in their home, and sometimes it's in a mobile unit, but it's outside of that pharmacy and showing people that there is help for them beyond what they've been taught to expect.
Yeah, this idea of kind of medicine without walls and really fostering proximity is really important, right? Kind of embedding yourself within community, to be with community, to really learn, really is a critical ingredient to the type of impact that we want to see. And so it's amazing to see how those investments are certainly helping to spark a shift in the ways in which we are operating and thinking. We're at a business school, so it's only befitting that we talk about business. And so, Dr. Cerise, one of the things that is remarkable to me, and I'm sure to you, is the scale at which Parkland operates, right? If you think about our budget, on the clinical side, the number of visits that we see, inpatient, outpatient. I was reading stats from the Dallas Regional Chamber, one of the top employers, right, in North Texas, over 10,000 employees. And so the business model itself is pretty complex, sophisticated, and large. And so I would love for you to kind of help us zoom out and zoom in to think about, as we're trying to reimagine healthcare, What are some of the ways that Parkland is trying to actually reimagine its healthcare, its business model, right? How do we actually deliver services? And I would love if you could maybe even give us some insight on some of the ways that Parkland in the past has partnered with corporations to look at how we kind of operate and find efficiencies or ways that we can increase efficacy in delivering of care.
Sure. So, I tell people we are the model of like bad business at Parkland, because we look at that CHNA map and you see where you do your modeling to see where you want to position your business, and we look and we see where most places in healthcare are going to say, okay, where are people that have insurance and have some income and can like make this a going operation, and we do like just the opposite. Where are the people that don't have insurance, are not likely to be able to pay their bills, need access, and we say, okay, we'll go there, and we can do that because the county funds us to do that work, and that's what we're supposed to do. But if you look at the population that Parkland serves, almost half of our patients are uninsured. About 2/3 of our funding is flexible funding from public sources, whether it's federal or local county sources. And it's flexible, which is important in healthcare because, as I was referencing before, so much of the dysfunction in healthcare is because it's such a fragmented operation, and you get paid for transactions. You don't get paid to manage a population. And because of the way we're reimbursed, it's actually kind of liberating that our reimbursement is not tied to that individual encounter. So we can look at things at a population level and say, how do we manage this better? So if we want to do hospital at home program, which we were just having a conversation about that this afternoon with our team, and that is, we'll, instead of admitting people to the hospital, we'll send them home and send a nurse and give them an iPad and get all their vitals, and we can follow them up at home. We can do that, and if the insurance companies will not pay for that, that's okay. If it's a more efficient way to do that care, and it's more convenient for the patients, then we can do more of that. And so in a lot of ways, we're not bound by the restrictions that the healthcare system imposes on us. If we want to have pharmacists, which we do, manage people with diabetes and hypertension, because oftentimes what those people in clinic need is somebody to spend some time with them to go over what their readings are and what their interventions are, and a nurse can do that, a pharmacist can do that. And we've studied this now and shown that people with poor control that get into those programs get better control. And so we're not bound by the traditional rules, and we break some of those rules in how we structure our care. But to your point about working with corporations and actually the sort of nuts and bolts of running an efficient business, we've had a couple of groups that we've worked with over the years. When Toyota moved their North American headquarters to Texas, we reached out to them. Toyota's famous for their Toyota Production System, lean business models, and so we reached out to them to say, hey, would you be willing to come look at some of our processes and help us? And we settled on a few projects in our emergency room where things can get really bogged down, and they sent a team in and flowed out the process for us and looked at how we could improve our throughput, just like they improved their throughput on the assembly line. How could we improve throughput? Understanding we've got safety concerns and all that we pay attention to. Right. And it was interesting, what they said is, yeah, we'd love to come do it. We have to have an agreement. We're not there to, we're not going to come and lay people off or any of those things if that's what you're looking for, but we'll come help you improve your processes. And so they did that. And we've used them now for a few projects. Our team likes it. Our industrial engineer type folks that do lean process improvement love to work with Toyota, and their team likes to come and be in the healthcare environment too. So we've worked with them. We work with Press Ganey has a team that does high reliability, and we've got a multi-year project now with Press Ganey focusing heavily on quality and how applying high reliability principles will improve quality and patient-centered care.
Yeah, I mean, we're really in a privileged position to be in a community with such access to the number of headquarters and companies that continue to move and relocate. And so I think the headline continues to be partnership, right? How do we come together? How do we take often out of sector, out of industry examples that we can apply and translate to the work that we do to think in some ways unconventionally about how ultimately to positively impact the life of a patient. And so really appreciate you lifting those examples and certainly a plug for continued ways in which we can kind of partner and forge partnerships to drive the work forward. Melissa, to that point, what has always struck me about the McKesson Foundation is the ways in which you help to build capacity with your partners, right? So the investment dollars are certainly important, and we are grateful for that support. But also capacity building and thought partnership really goes a long way to foster sustainability and, again, changing dynamics at play. We'd love if you can talk a little bit about that work, right, that you all continue to do to build capacity across communities in which you serve.
It's generally looking at like or complementary partners and within one city or other. So within the foundation, in the U.S., we support programs here, Memphis, Houston, Richmond, Columbus, Ohio, and Atlanta. And you see many of the same challenges across all of those cities. And then you see somebody doing something so spectacular that you want the other ones to know about it. And so we help connect some of those partners. Sometimes somebody is, by virtue of their location or a hard year with funding, maybe they were relying on things that just aren't available right now anymore, and so they're having to rethink how they do things, or the population that they're serving just has different needs now. So identifying opportunities for partners to share with each other has been helpful for several of them, and we always enjoy kind of connecting people. And then being able to kind of introduce new concepts, especially the more innovative ones, with others. So for instance, food pantries. Love them. And I think whenever anybody who needs food gets it is wonderful. But if I had my preference, I would do the pantry shop model so that people have choice, because you mentioned agency before, right? So you want people to be able to go into a location and look at and choose what they want. And I think besides the dignity of choice, you also probably have less waste because they're picking what they want.
Right.
So looking for ways to improve that model so that that's more the model that people are using. Also helping partners, we'll give funding to help them expand the hours. If you only have enough volunteers or paid staff to run your pantry from 9 to noon on Tuesdays and Thursdays, you're missing some people. So there are some models that are doing great work with food lockers. And so they've got cold storage units, and you can go and pick it up when it works for your schedule, and what you've requested is going to be there waiting for you. Or how can you help patients who have diabetes or heart disease and are using a food pantry make wiser choices when they're in there? And so we know that there's a lot of canned and packaged foods just by virtue of a food pantry, but we direct a lot of our funding to the proteins and fresh produce so that people have those choices. And then if there's an opportunity to support a cooking class or some other educational opportunity, so that, if you've never seen a whole eggplant before, somebody can show you how you can make a good, nutritious meal for your family with it. And so those are things that we try to do that I don't think, none of it's rocket science, but sometimes just sharing those resources with other people, and also looking at the numbers to see how much greater impact you can make when people have the choice of what it is they're shopping for, and how it improves their diets with those choices and the cooking class.
Yeah, I mean, as we think about changing behavior, education, choice, right? These are critical ingredients and factors to get to the end outcome that we want to see. Is kind of one takeaway. The other piece is just the kind of, again, the power of philanthropy, and I can't underscore, to bring groups together, right? To convene to foster conversation and certainly new ways of thinking that otherwise, if we stick in our silos, we may not actually be able to capture. And so, again, really exciting, and just appreciate you sharing those stories with us. So Dr. Cerise, we know, well, first off, for those who are tracking, I would encourage you, please scan the QR code. I love technology, and I think we're gonna get to some technology questions soon. But we'd love to hear your questions and your voices if we could. So we started, Dr. Cerise, with Todd's comments about the AI for Healthcare Leaders program that Parkland has certainly been a part of. Everyone is continuing to hear about AI. We'd love for you to kind of like just push us.
More AI.
Yeah, let's get in there. Like how is Parkland leveraging kind of different digital health modalities, right, to again kind of disrupt and reimagine how we deliver healthcare is kind of the part of the question. But on the back end, I want you to also talk about, as we do that, what are the guardrails that we're putting in to make sure that whatever technologies we are employing, we're doing so ethically, right, and really holding the patient, right, at the center of the work that we do.
Sure. So boy, there's so much there. Parkland's been doing this for years now. I'm looking at Nicole and the work that you guys have supported with Ruben in the early days of PCCI, where for more than a dozen years now, we've been doing predictive modeling, looking at, as I talked about customizing care, looking at who's more at risk for certain conditions and how do you focus attention onto those individuals as opposed to trying to focus attention on everybody. And so, we were able to identify people that are at high risk for hospital readmission based upon their conditions at discharge. And I've told this story a bunch of times, but when I first met Ruben and was looking at this model, and we're talking about we can predict who's at high risk for readmission after they're admitted for heart failure. And I'm thinking as a physician, okay, it's going to be, did they get their medicines at discharge? Did they get a follow-up appointment? Did they get good instructions? And the bigger predictor than any of that was, did they have 3 or 4 different addresses in the past year, which really puts you down a different pathway in terms of interventions that you need to pay attention to keep somebody out of the hospital. And those were kind of the early days of those predictive models. And now, our team at PCCI has developed a number of predictive models from, who's going to have asthma exacerbations, and so who do you need to pay more attention to on the outpatient side with asthma, who in the hospital is more at risk for cardiac arrest, who's kind of gone south and you haven't recognized it yet, but based on real-time vital signs and drugs that are being ordered and things like that, who needs to get attention to. And I've got multiple stories of our rapid assessment team going to a bedside to identify somebody that nobody else has identified yet, but who's on the edge of getting into real trouble. And so there's a number of things like that have been going on for years. Now, things have moved to be even more sophisticated, if you can believe it, in terms of what AI is able to do. And so we have we try to. Right now, AI, what you do in AI is basically how much can you consume, because there's so much out there. And when we look at our digital health team, that team is doing that and helping us understand what we can adopt in terms of AI. They're also doing a lot of not high-techy AI stuff, but telehealth and things to make care more convenient to patients. And so we're doing over 100,000 telehealth visits a year now through this digital command center, which is like a big community clinic for us, except it doesn't have patients coming to it. It's broadcasting from that digital center. But to get to the AI and how we're using AI, we are kind of looking at it in terms of the non-clinical stuff that can make your business operations run better. And our approach to that is generally using the tools that the big vendors and the tools that we use, the 3Ms and the Kronos and the Workdays, UKGs, and those organizations that have these now more and more embedded to help you with things like, coding and doing your referrals and managing work schedules and things like that. And definitely kind of moving into that space, which is important and barely excites me because the clinical stuff is just so much more intriguing. And so when you look at the clinical side, it really is transformational in terms of what AI is doing, and it's causing a lot of us to grapple with how do you ingest this. I do work with the American Board of Internal Medicine. AI can pass the medicine boards today, and it does really well. We are using residents commonly are using an app called Open Evidence that helps them to say, I've got this 55-year-old man that's got this set of symptoms. What do you think? And it will give you the differential diagnosis, and it's really good. We're using it in imaging. We're working with a company called AI Doc, and it can read X-rays, and it does a really good job of reading X-rays. In fact, if you look at people who have had serial mammograms and then have a mammogram that shows cancer, if you look back a year or two, the AI app will pick it up, would have picked it up a year ago or 2 years ago. And so when you talk about ethical use of AI, one of the questions that comes up is, when is it ethical not to use AI? Because we get concerned about it does make mistakes. It's not perfect. There's a guy named Bob Wachter who wrote a chair of medicine at UCSF who just wrote a book about this. And in the book, he says, don't compare me to the almighty, compare me to the alternative, And when you consistently compare AI to what clinicians are able to do, it's better. Now, it doesn't. Again, we're not at the stage of not having the clinicians in the loop and working, taking the information. But I think we are moving to a different phase of medicine where there's going to be so much capability there that the physicians are going to have to approach this with a sense of humility and change in our work, so that when patients come in and they've got, they can take their medical record and tell ChatGPT, summarize this for me and tell me what I should ask my doc about, at this visit, and they come in with this. It turns you into much more of a consultative role than I've got the answers and I'm going to tell you all the answers.
Yeah, I want to stay on that theme and go off script a little bit. We talk a lot about trust and the importance of trust in that sacred space between a clinician and a patient. What impact do you see, right, the increased agency, right, that technology can provide a patient when they're able to look at their records and kind of come through a diagnosis? And how that impacts the dynamic of, right, a clinician where you're not like the all-knowing person, right? But you're having to really kind of work as a facilitator of information. How does that impact trust, right? Because we still need trust to be built and sustained.
It's a great question. When you look at the things that make people distrustful of the medical system, it's things that, they can't get an appointment. They can't get in. They can't afford it. They're getting huge bills. And so it's hard to be trusting of this system that is not working for you, right? And so it's not a surprise that people are going to turn to AI. It's always available. It's affordable. It gives you good answers. It's empathetic, right? It talks to you in a nice way.
Hopefully, yeah.
Right? I mean, there's a study looking at using AI bots to answer MyChart questions. Patients, send in a question in MyChart and using bots to answer it. And they compare it to the physician responses. And what it showed is that it's more accurate than the physician responses, and it's more empathetic. Because that's one of the concerns as well. The patients are not going to, it is so. But back to your question about trust, I think we have to recognize that there are reasons why people kind of have lost confidence in the system because it's not been working for them. And so AI is a place where they can turn and get a lot of the stuff they're looking for out of the health system. And so how do we then, as the health system, as clinicians that are working with those patients, recognize that, acknowledge that, and say, okay, how can I work with you to say, let's help you interpret, or let's help you say what to do next. Because what AI is not as good at is the medical decision making and reasoning. And if you think about it, it's good. It's great at diagnosis. It's good at that too, but it's not as good. It's good at diagnosis because there's just so much data that we have put into the system to say these symptoms equal this diagnosis, and it's got a lot to pull from. But what it doesn't have to pull from is, I'm seeing you, Michael, and this is what you have, and then I'm thinking about, okay, what are the options for you, and what do you prefer, and what's your family situation? A lot of that's going on that you don't write down in the chart, but that you're considering in terms of what's the right treatment option for you, and that's still going to be the role that the clinicians have got to, and I think we have to just kind of embrace that world's changing, but there is still going to be a really important role to play, because I don't think we're going to get to the point where it's totally human out of the loop.
Yeah, no, that makes sense. I have a teenage daughter, and so I'm embracing change and technology, and so I'm on that journey. I think many of us in the room are doing that. I would love, so first, please continue, if you haven't done so, to submit any questions. We want to certainly open up this conversation, and I know I'm looking across to see so many friends and thought partners and leaders in the audience, and so I know you are going to help us really generate an even richer conversation. Melissa, I would love to stay on this theme, but shift gears in the idea of, as you are looking at philanthropic investments to make, how do you balance, right, the kind of shiny, innovative, right, approaches that are actually taking place using technology and AI with some of the more traditional, low-tech but high-impact opportunities that exist? You mentioned, shifting back to food, right, that there are things that can be done, right, that don't require, right, a neuroscience degree, right, but to focus on providing dignity, right, choice, options for individuals. I would love to just kind of peel back the curtain a little bit as you are looking at opportunities to invest in.
We try to strike a balance. So we know that not every organization is going to have the infrastructure. So you might have great ideas, but one of the things when we get proposals, we have a rubric. And one of the things we look at is the organization's capacity to deliver what they're proposing, right? There's a lot of great thinking out there, but do you have the right staff? Do you have the additional funding, the right technology to actually do this? So sometimes that knocks things out. Yeah. But then there are other situations where they have it all, and it's really a cool prospect for us to be in, either to help them grow something or develop it. And we just try to strike a balance between our three giving pillars. So it's reducing the burden of cancer, preparing tomorrow's healthcare workforce, and accelerating crisis response. And we don't shy away from AI or technology. And you can't attend a meeting at McKesson in the last 18 months without having somebody talk about AI and ask what you're doing. And so it's really important, and the foundation board loves to hear when we're able to use it. So we use it within the foundation when we're assessing the finances for organizations, because we want to make sure they're strong financially. And then we also appreciate learning about opportunities with partners. So I know there are food banks that are looking at using AI to help patients make those choices when they're shopping for their food. And then I spoke with somebody in the eye space recently, and they're using AI, training people with a high school diploma to go into Indigenous populations in Canada to go through the backlog of eye screenings that, I'm trying to remember the time period, but it was months of backlog that they got through in weeks. Wow. And the accuracy was fantastic. And so, we talk about some of the things that prevent people from good health or economic stability. Not being able to see well is one of those things, right? If you can't see well, you might not be able to do your job safely or at all. You might not be able to drive anymore. You might not be able to care for your kids safely. And so when you have huge swaths of the population who need an eye exam and corrective glasses, or maybe even just readers, and getting that screening for them and getting them those glasses, or diagnosing glaucoma or diabetic retinopathy or macular degeneration or cataract, all of those things are treatable, but if they go too long, then there's irreversible vision loss. And so the fact that they are using technology and enabling somebody who has not gone to college to be able to deliver that care to hundreds of people so quickly is phenomenal.
that's a great example.
And we'd love to be able to support things like that. So some of those things are within our means to support, and others are, financially outside of our means, but we always love to hear about them.
Yeah, I love the approach, both internal, right, to the organization, but also looking at, right, that balance and how technology really can be an advent for change in areas where it's desperately needed. So, awesome. Thank you so much. This is good. This is good. So a couple of questions that are coming in, and so let's start here, Dr. Cerise. So the question is, in the past CHNA reports that Parkland has produced, there was a clear focus on building out community health clinics to bring care to communities, relieving the burden really at Parkland, the main campus. What have been the successes and challenges with that approach of really kind of getting outside the main campus and trying to expand our community health presence?
First, how we doing on time?
Yeah,
I'm curious if I go long or
Yeah,
short.
we got, I would say as concise as possible.
Well, it's one of the access is access. You asked me what our issues are. It's access, and we've tried to spread it away from the campus. And so, by comparison, we'll do 70,000 discharges a year at the hospital. We'll do 1.3 million outpatient visits at our clinics. And so, we've added bricks and mortar. We went down to Redbird. We're building up at Richland right now. We'll be at Esperanza. That'll be out this summer. We've acquired property in Inland Port down in Wilmer to do something there. And we have a big project coming up at Southeast that'll be a replacement and an expansion, because people want something closer to the neighborhood. We're trying to decompress the main campus as much as possible. If we can push that primary care off of campus, then we can create capacity on the main campus for all the specialty stuff that we need to do there. So physical access points has been a area of emphasis. And as I mentioned, our digital health center, that's the other part of this two-pronged approach, is that we're doing 100,000 visits now. We expect that to grow even further. Patients like it. It's more convenient. It addresses some of the things with transportation challenges, getting off of work challenges. And so, we've significantly reduced our wait time in a number of clinics as a result of that. But it's going to continue to be an ongoing focus, because Dallas is growing. There's going to be a growing need, and but doing more away from campus is a good thing.
Awesome. Thank you. Melissa, there was a lot of excitement and interest in the specific examples you were providing, particularly around the Mentoring Cancer Patient organization. If you could revisit that and give us the name of that organization.
Sure, it's Imerman, IMERMAN, Imerman Angels.
Awesome.
And they're in Chicago.
Wonderful. For those that are interested, please look up, and we definitely will follow up. That is amazing, and thank you for offering that as a shining example. Another question here. A lot of what it appears that we're talking about as it relates to health outcomes and what are the factors that impact health outcomes is related to educational attainment. It's no surprise that there is highly correlated, right? Educational attainment and health outcomes. Would love to hear a little bit more, and certainly Dr. Cerise, if you could jump in here about kind of work that Parkland has done, particularly in under-championed communities where there may be assumptions, right? Distrust about healthcare and kind of clinicians and how that impacts, right, their life. What is Parkland doing to really develop programs or approaches that really work to both engage white populations where there may be distrust, and really activate, right, their engagement and interest, right, in partnering with the health system?
Yeah, first thing I would say is, you're touching on some of the social drivers of health outcomes, things outside of healthcare that have a real impact on health. So economic viability, education, those types of things. And so I shouldn't say this as a healthcare provider, but investing in early childhood is really important.
Yes.
Because if you can address
Yes.
issues at that level, then we have a lot fewer issues that by the time they get to the hospital. And that's just that's just a fact. I mean, so much that we see in healthcare is caused by those other environmental circumstances. So, but to get to your point on education, and it's another thing that comes out in the CHNA. I'm looking out here, Angela Morris. This is the work Angela does, and partnerships and getting out into the community. Another thing that came out is people want more education. They want more programming. They want better understanding, and so we work with a lot of community partners, a lot of churches. We do a lot of screening events out in the community where not only we're screening for disease, but we're also doing educational pieces. And then importantly, a lot of people do that part of the business, but then the business of healthcare doesn't support the next step, which is, you diagnose somebody with a problem, how do you get them in and treat? And so a lot of our outcomes are tied to actually when we identify stuff through our education programs and through our screening programs, do we actually get them into care, which is the other important piece of that. But, trust is a lot about showing up and being consistent. And when we look at our models and we may say, we went to do this community event and there was only a handful of people there, was it really worth it? A lot of times it's about showing up and being there and being consistent. It's a long time play.
Yeah. It is a long play. And so with that in mind, as we wrap up, Melissa, I want to close out here, knowing that it is a long play, all right, and it's a marathon, not a sprint. What gives you hope, and what's the message, right, to our community of things that we can do, right, to support the types of improvements that we talked about tonight that we'd like to see in our community?
I'm inspired by the dedication of some really small staffs with huge hearts and lots of curiosity and tenacity. And so they see people in their community who need help and they want to figure out a way to help them. I appreciate that. I also appreciate so many of the students that are coming up. A couple of weeks ago, one of my colleagues and I had the chance to go to one of the student-run free clinics from SMU. No, excuse me, I'm sorry. UT Southwestern, I'm sorry. Pretend I didn't say that.
We're all in the family, our friends too.
Southwestern has student-run free clinics. We went to one of the clinics where they have medical care, dental care, vision care, a food pantry, a clothes closet, and behavioral health. And talked to the students, and two of them were there, and they both had different paths that they had considered until they started working in that capacity, running those clinics, seeing the impact they were having with those patients and their families. And one is going into family health, and the other one, because she'd planned to be, I think, a surgeon, and she saw the need for more OBGYNs in Texas by working at this clinic. And now that's her chosen path. So sitting there and watching these med students, on top of their really grinding responsibilities as students, take on running free clinics and being there day in and day out for, I think it's 5 or 6 that they run in the area. Knowing that they are so committed to that, that gives me hope. And they're looking for ways to make sure that that care is accessible, that it's culturally informed, that it's provided with dignity, and just like at Parkland, that it's done in a way that isn't in any way less than, right? It's the care that they would get going to any other hospital or clinic.
That's right.
Where the patient is insured and they're thinking, and the level of expectation that a patient going to these free clinics should be just the same as somebody going to another hospital. And the students are so committed to making sure that the experience and that the care is nothing less than top notch. That gives me hope.
Yeah, inspiring. Thank you for sharing that. As we close out, Dr. Cerise, kind of what gives you hope, right? When you wake up each day and go to the hospital and you're out in the community, what gives you hope and what messages would you leave us with?
Yeah. It's easy to be cynical in healthcare right now. It's a lot of corporate influence. The people practicing feel like they've got less agency, control. Patients are, struggling with the things that we talked about. And, the groups that I sort of talk to, you hear a lot of that. But just what you said, Melissa, the people and the commitment of people, it still tells you that medicine is something that's there for the patients that need it. So I thought of the past few weeks we had this ice storm, and so people couldn't get back and forth to work. So we made accommodations for people to be able to sleep at the hospital. Several hundred people slept on cots in one of our clinics for several nights so they could be at work to take care of patients. And so I was walking around the hospital and talking to people, and consistently, I was afraid, you might get people who are grumbling and, not happy. But I talked to the housekeeper and asked, hey, were you able to get into work? And she said, no, I slept here. And then we're thanking you for being able to sleep at the hospital. Or I talked to a nurse in the ICU, same thing. This one was going back and forth. And she said, well, of course I had to come back because I had to be here to take care of patients. And so there's just this real attitude that they had to be. This is what they were meant to do. And so, for those of us that are on the business side have to be concerned about all of the really hard parts of how do you make it affordable, how do you make it accessible, you can forget about that. But the people that are actually doing the work and in those clinics that are interacting with patients, there's still the heart for it and the desire to take care of people. And for that reason, I'm still hopeful.
Well, thank you. Please join me in just thanking our panelists. What an amazing conversation. Really, thank you so much for helping us elucidate that intersectionality between health, business, and innovation. And certainly want to thank each of you for joining us tonight. You could have been anywhere in the city, in the community, but you chose to be here. And we thank you for standing not just with us here tonight, but across almost 40 years of service that Parkland Health Foundation has really leveraged the power of philanthropy to change lives and really support and advance the mission of Parkland Health. And so call to action is really important. And there are a couple of things that I would encourage you to do before you take off and tackle the next thing, whatever that may be. One, share something that you've learned tonight with a friend or a colleague. Much of what we talked about, right, is complex and it's not going to be solved overnight. But certainly, as we've pointed out in the conversation, there are a multitude of examples of bright spots all across the community and really the country. And so I'm encouraged, right, to know that a lot of that work is generated by conversation, community coming together and convening. Number two, right, I would encourage you to also read the CHNA. I kind of made a joke about bedtime reading. Take it in chunks. But for how many folks are taxpayers in Dallas County? Don't be shy, right? I'll raise my hand as well, right? We thank you, right, for the investment you are making, but it's important, right, as investors to know how your dollars are being spent. And so I would encourage you really to take a look, right, learn about the work that we're doing, not just the challenges that we're trying to confront, but the innovative approaches that we are taking in community and in partnership with so many organizations such as the McKesson Foundation. Then finally, I would be a poor fundraiser if I didn't also acknowledge the fact that everything that we talked about tonight, the through line was philanthropy, right? It is really an underscoring of the power of private capital creating opportunities to scale up innovative data-informed practices, to seed investment, right, in those organizations that are really trying to bring change and agency to communities. And so there's an opportunity to learn more about the work that we're doing at Parkland, and I have colleagues that are here and excited to talk to you. But thank you again. I hope that you leave encouraged. I hope that you leave informed. I hope that you leave connected and part of the community that we're building. I'd be remiss if I didn't thank SMU. Thank you so much, Todd. Thank you for hosting us. My dear friend Lisa Tran, Dr. Tran, thank you so much for all that you do for SMU and certainly a partnership right, with Parkland. If you are a member of the host committee, if you're able to stand, please stand. If you don't want to stand, wave. I'd love if you just show your yes, 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 yes. Right. Again, community bringing community. Thank you so much for all that you did to help us generate what we thought was a robust and rich conversation. So on behalf of Parkland Health and Parkland Health Foundation, we wish you great tidings, health, and certainly a great travel home. Thank you so much.